Good afternoon, everybody. I'm going to talk a little bit about a couple of topics this morning. One of them is something that's probably already on your mind, and the other one is one that will soon be on your mind. We'll start with the one that will soon be on your mind, though. We'll be touching bases on the home and community-based settings rule. That we have some new activities coming up with that very soon, and then we'll finish up with patient responsibility for recipients in assisted living facilities. So first, home and community-based settings rule. How many of you are familiar with the home and community-based settings rule? All right, so there's at least a few, and the rest of you are probably too sugar-laden from that gigantic Rice Krispie treat to raise your hands up, right? So HCBS services allow recipients to receive services in their own home or community instead of in an institution. The HCBS settings rule was developed, my first experience with it was in 2012. They were in the process of rule development at that time, and people from Centers for Medicare and Medicaid Service came down to Florida. We were just starting and rolling out the long-term care program. They went with us on a tour of a number of different ALFs in the Orlando area, and kind of talked us through what their mindset was about the home and community-based settings rule. Fast forward to 2014, and the rule was finalized at that point. And then in 2015, we implemented a provider self-assessment. So the agency did quite a bit of training showing that really intensive tool. Providers did a self-assessment that they submitted, and then we developed from that a statewide transition plan that talked about I'm getting a beeping. A statewide transition plan that talked about what we would need to do to come fully into compliance. That takes us up to what's coming this year, where we're going to be going back, revisiting, and actually checking to see which facilities are compliant with the HCBS settings rule. All right. Oh, I'm one behind already. All right. So with the HCBS settings rule, this is a federal rule. It allows people to have access of setting where they can have a choice of living in a place that meets these kinds of characteristics or has these qualifications. The first one is access to the community, being able to go out, be involved in community activities, whatever those activities may be. A freedom of choice when they're choosing a setting of where to live. So I want to live in this place or that place. They have some choices about within the facility of the kind of room that they may have, roommate they may have. Safeguarding their rights to privacy, dignity, respect, and freedom from coercion or restraints. Optimizing their independence. And then a choice of services and providers. So while the person might choose to live in an assisted living facility, they still have the ability to choose different providers. Not anything like a nursing facility where you have people who come in and they're the people who serve that facility. You have a greater choice in the setting. And then the last one, if it's a provider-owned or a controlled residential setting, it gives people the same kind of privileges that they have if they were a tenant living in the community. They have the right to notice and those kinds of things. They have the option to choose to live in a private room if they can do so. That's, we all know that you may not have the resources to be able to choose to do that, or maybe you have to find the extra resources to do so, but it's a choice that they can make. They have control of their daily schedule. They can choose whether to participate in activities or not. Unrestricted visitation, that was one that I remember being important to CMS, is that something that people have the opportunity to have others come in from the community and visit them. And then that it's physically accessible, of course. So these are all the settings where we will be taking a look at home and community-based settings characteristics and whether or not these are meeting the requirements of a home-like environment. Some of these you don't necessarily think of for adults, foster care homes. This is a rule that applies to both adults and children. So it's going to be used across a variety of community-based settings. So in the coming months, the plans are going to start compliance reviews of these different settings, and they'll have extensive training on the rule, the tool that we'll be using to assess compliance, and then the agency's expectations, what exactly they need to look for, and the end goal that we're looking for. And of course, during that time, we'll have a high level of communication between the plan and the agency to make sure we're all on the same page. Based on the assessment results after that, then settings are going to be characterized into one of the following categories. They're either fully compliant with the rule, they're non-compliant with the rule and they need a plan of remediation, or it's a setting that's considered presumptively institutional. Now, presumptively institutional is the one we're going to focus probably the most on. The second one, there may be some deficiencies, but it can be remediated fairly simply. Right. So when a setting is presumptively institutional, they're looking for some particular characteristics. For one, it might be in the same building or on the same grounds where there's an institutional setting that's located. Now, being located in the same building or on the same grounds does not necessarily in and of itself mean that it's absolutely a no-go and it's institutional, but there are some questions to be asked and answered to make sure that it's still a home and community-based setting, that it is a home-like environment. We'll also be looking at whether the facility has the effect of isolating people who are receiving Medicaid home and community-based settings from the larger community. I think we talked on one of the earlier slides that the goal is for this person to be able to be involved in the community to the fullest extent possible. All right, now once all of these assessments are completed and that information is pulled together, the settings that are preliminarily identified as potentially meeting presumptively institutional characteristics are going to get a copy of the written findings from the plan, and they'll get a copy of the assessor's completed report. They'll have a chance to provide extra information that shows that they're not an institutional setting, or a chance to come into compliance. So kind of similar to that second category, there are deficiencies that are identified there, but they do have the opportunity to remediate those. Now, settings that are not able to come into compliance, settings that are deemed presumptively institutional and don't come into compliance, it is required that the state terminate those settings from the program. However, the good news is this is largely within your control. You'll have all of the tools that you need to determine if you're a setting that's presumptively institutional and what needs to happen in order to bring that into compliance. And I'm sorry, I really do wish I remember the numbers, but I do recall from discussions about the earlier assessments that there were not as many presumptively institutional settings as one might have thought. It was a fairly small number. So this is good news. While there may be other facilities who need a little remediation, presumptively institutional is pretty isolated. All right, so if you have questions about that, we'll direct you back to your long-term care case manager for any of your recipients' plans. If you can get additional information on the home and community-based settings rule on the agency website, I believe we even have some of our previous PowerPoint presentations still posted, so you can get a good overview of what that is and what it means for you. Now, one that I know has been a topic of discussion, patient responsibility for recipients living in assisted living facilities. And I'm going to mostly go a little bit over kind of how this comes together, how that gets determined. And I think that we have some other questions that come up for the panel today where they'll talk a little bit more about those aspects, other aspects of patient responsibility. So what is it? Patient responsibility is the amount that an enrollee needs to contribute toward the cost of their Medicaid long-term care services. DCF determines this. They do that based on the recipient's income and the person's choice of residence. Now, when you come into a waiver, if a recipient, if a person comes into a waiver like they would in the long-term care program, they have higher income and asset limits. So they aren't meeting the traditional Medicaid income and asset limits. They may have a little more. So this is where patient responsibility starts to come in. There are a couple of terms, and sometimes I think I hear them used interchangeably, but these don't mean the same thing. There's patient responsibility, which is that amount that the recipient is paying toward the cost of their care. But then there is share of cost. And share of cost, when you think about that, you want to associate that with medically needy. That's somebody who meets so many of the criteria, but they don't yet have full Medicaid. They have more income and asset limits, income and assets than what would traditionally be the case. And they have to do a spend down before they can access full Medicaid. So share of cost is medically needy, and share in cost is your home and community-based settings folks and their patient responsibility determination. So as I told you, DCF determines patient responsibility. DCF is the only entity that can determine patient responsibility, and that's even for people who have Social Security income. They have a process, they've got a rule, and then there's also federal rules that also regulate how patient responsibility is determined. They have some good tip sheets on their website I'll point you to if you want to understand how the sausage is made a little bit better. And the key components of patient responsibility when you have a SMMC long-term care enrollee who's living in an ALF, the key pieces are their income, their personal needs allowance, and their uncovered medical expense deductions. So I'm going to talk a little bit about personal needs allowance and uncovered medical expenses, oftentimes also called UMED. So the personal needs allowance is the amount DCF calculates that the person may keep to pay for their personal expenses. And that amount is made up of the monthly room and board rate for the facility where the enrollee is living and 20% of the federal poverty level. That changes each year. I think in my slides I had 2016 as an example, but you could look up a federal poverty level amount for 2019 and kind of roughly do the math for yourself as well. So here's an example. Let's say this person lives in an ALF and they have a $1,500 monthly ALF basic room and board charge. Add to that 20% of the federal poverty level. In this case, it was the 2016, and you'll see this is their personal needs allowance. In this case, it's $1,698. There's more math involved, though, not to frighten you away. So what is an uncovered medical expense? Uncovered medical expenses occur when the recipient incurs a charge for a medically necessary service that isn't covered under the Medicaid program. DCF will ultimately reduce that personal needs allowance by the cost, by any unmet medical expense costs. Those are your UMEDs. These can be premiums, deductibles, or co-insurance charges for health insurance, or they can be other medical expenses that are approved by DCF. A question we sometimes hear is, what about the ALF room and board charge? The room and board charge itself isn't considered an uncovered medical expense, so it's not counted in UMED. Now, DCF can adjust this patient responsibility amount. If the person's UMED goes up, they have more medical expenses that aren't covered in a month, then the patient responsibility would go down. If the person came into somehow more income, then their patient responsibility would go up. Or, vice versa, if their income went down, their patient responsibility would be reduced. So how does DCF use the personal needs allowance to calculate patient responsibility for somebody who is in home and community-based services and resides in an ALF? To calculate the patient responsibility, DCF is going to reduce their total gross income by the amount of their personal needs allowance. So for example, this person may have a total monthly income of $1,750. Now, you remember that previous math problem we did? We took away the $1,500 for their ALF room and board charges, and the $198, which was the 20% of the federal poverty level, and now we're left with this person has $52 in monthly patient responsibility. That $52 is the amount that they're expected to pay toward their long-term care costs. All right, so health plans are responsible and under the contract for collecting the patient responsibility for somebody who may have MMA or LTC benefits. However, the health plan can transition that responsibility to its contracted providers. We have some provisions in the contract that give them some directions on what they should do. So you would see that in your agreement with the health plan if you as a provider were responsible for collecting the patient responsibility from that enrollee. All right. How does the health plan collect the patient responsibility? If they're delegating the collection of patient responsibility to the provider, in this case the ALF, we have the monthly rate for ALF services. This would be assisted living services in the long-term care program, or it could be assistive care services if they're in the MMA program. And let's say that amount comes up to $1,200 in a month. Take off of that the $52 for patient responsibility, and the plan would pay the ALF $1,148, and the ALF would collect the $52 in patient responsibility from the recipient. If the plan doesn't delegate that to the assisted living services provider, then the plan would pay the ALF the full amount, and the plan would collect the $52 patient responsibility from the enrollee. All right, so there are some instructions on how to find this information on DCF Provider View. For nursing facility services, the agencies managed to automate that so that that amount and those updates that occur come across, and that information can be provided to plans automatically. We still have some work left to do to accomplish this for HCBS enrollees. So for assisted living services, for folks living in an assisted living community, the source of truth in this case would be DCF Provider View. That's the source of truth for both you as an ALF provider and for health plans as the insurer. All right.